Welcome back to Open Med School. The last session we have discussed about initial assessment of patient suspect with acute ischemic stroke. So today we'll be discussing about antithrombotic therapy in acute ischemic stroke and TIA. As mentioned, time is brain. Early interventions reduce long-term disability. During the initial assessment, you will be looking for whether the patient is a candidate for reperfusion therapy, that is thrombolysis, or mechanical thrombectomy. No antithrombotic agents, that is antiplatelets or anticoagulants, be given within 24 hours of thrombolysis. Remember this point. So the initial step will be restore perfusion, TPA bar thrombectomy or TPA plus thrombectomy. Second goal is prevent early recurrence with antithrombotics. The antithrombotics are antiplatelets and anticoagulants. Today's discussion is on antiplatelets. Antiplatelets are started as early as possible. If no thrombolysis, there are no bleeding risk and patient can swallow safely. First is aspirin monotherapy. Dose is anywhere between 165 to 325 milligrams per day. What are the indications? The low risk TIA, that is ABCD to score less than 4. Moderate to severe ischemic stroke, that is NIHSS stroke scale more than 5. Aspirin monotherapy is given within 48, preferably within 24 hours of stroke. It reduces recurrent stroke with minimal bleeding risk. The number needed to treat is 79 to prevent death and disability and 112 to prevent recurrent stroke. So it is an effective treatment. The evidence is from international stroke trial and Chinese aspirin stroke trials. Most effective, as mentioned, given within 48 hours of onset. So now we think about the role of dual antiplatelet drugs or DAPT. The indications are TIA ABCD to more than 4 and minor stroke, that is NIHSS stroke scale less than 5. If it is more than 5, aspirin alone. Large artery atherosclerosis. Double antiplatelet therapy in the first 21 days significantly reduces recurrent stroke without mortality as per point and chance trials. So how to start? Aspirin plus clopidogrel is the preferred one. As mentioned, indications are high risk TIA, that is ABCD 2 more than 4, NIH stroke scale less than 5, intracranial large artery atherosclerosis, that is 77 to 99% stenosis. So remember these points. Aspirin, initially the same dose 160 to 325 milligrams as a loading dose, then 50 to 100 milligram daily. Clopidogrel, a loading dose, usually 300 milligram, 300 to 600, usually 300. Daily dosage then 75. Dual therapy is given for 21 days. Up to 90 days in large artery disease, then switch over to monotherapy. Why dual antiplatelet therapy is not continued? Because the benefits risk ratio, the risk is bleeding. Prolonged dual antiplatelet therapy increases bleeding without added stroke prevention as per the MASH trial. So DAPT, this efficiency, the risk of major bleeding increases with prolonged use beyond 90 days. That is why the cutoff time is 3 months. So in summary, indication for aspirin, TA ABCD score less than 4, NIH stroke scale more than 5. The duration is indefinite. DAPT or double antiplatelet indication TAA ABCD2 more than 4 and minor stroke, that is NIH stroke scale less than 5. Duration 21 to 90 days depending upon the situation. Early secondary prevention is crucial to prevent early recurrence after TAA or minor stroke. So clinical pearls, always perform dysphagia screening. DAPT is not recommended long term. Infarct volume, not just NIH stroke scale, should guide antiplatelet intensity due to the bleeding risk. So when a large infarct is there, the chance of bleeding is more. Anticoagulant, that is why dual antiplatelets are not recommended in large infarcts. Anticoagulants are not used routinely unless there is a sure and clear cardioembolic source like atrial fibrillation. Initiate antiplatelet therapy promptly after stroke confirmation and safety assessment. So in conclusion, early antiplatelet therapy is effective. Tailor DAPT based on risk. Every minute counts. Early therapy prevents future events. Stay tuned for the next session on the role of anticoagulants in ischemic stroke. Thank you.